Thank you very much for having me here. So, yes. Yes. Okay, fair. So, just a word, classification, A, B, C, D. No, I don't go into detail about that. So, what is coming to PVR straight C, you can see a variable pictures, and that's why your management change accordingly, case to case, you have to variable. Those scleral buckling, still all of us agree, Dr. Subhadra said, gold standard, particularly uncomplicated cases. However, most eyes with advanced PVR, they are not amenable to scleral buckling and would need vitrectomy as well. So, if you are planning combined buckle, obviously you open conjunctiva. I still prefer, if you have given option, I at least add encerclage, all these cases. And what is important here is when you deal with these cases is membrane dissection and how you handle this. Basically, what you is always instrument is a surgeon's preferences, but goal is to relieve all the traction to make the mobile retina, what you see top picture, to get something like this at the end you want. And technique, again, depends on location, extent, vascularity of the membranes. You can use bimanual or unimanual section, and depending on, particularly want to make the retina more mobile. Fortunately, of course, PVD is an important criteria for all of us. But in most of these PVR cases, except probably pediatric age group, I would say, posterior hyaloid is already separated. So when you talk about this critical stage, how to peel, you may have focal PVR, and then easy to use peak or forceps or your cutter. Now there's 25 or 27 cutter to create the edge between those folds, get the edge and use your forceps to peel that up, and your job is done. But sometimes it does not work that way. You have membranes are extending, retina is mobile, and the second video, as you see, and as you try to peel off, you don't have counter traction. You have, and then use a disc probably as a counter traction, peel from center towards periphery, slowly try to tease them up, and if necessary, occasionally use your light pipe to support the retina there. Push it, hold it back, and peel the membrane off. You are not pushing the retina too much, but basically light pipe will help to hold it on. Yes, the most important factor for all of us is identifying immature membranes. You see, sometimes practically you can't see any membrane initially, but as you keep on teasing, massaging retina, slowly you get those thin, flimsy membrane. Indication would be sometimes lot of pigments you see on the retina, and that's another indication. You start teasing, and when you get that edge and start peeling, probably you realize here that entire retina was covered with the membrane, and you need a lot of time to spend with him, lot of patience, go around, keep on, and because these membranes are fragile, they just come at bits and pieces. So it's not like that you start peeling and one go they will come compared to mature membranes as you saw. So you really have to go every millimeter of retina, inch by, and slowly get whole thing out to ensure retina is fully mobile here before going to other steps. Yes, membranes are sometimes tough. Periphery, either you can use directly bimanual, is the other video you see, but sometimes your light pipe itself can act as a bimanual second instrument. So here what actually I was doing is membrane is holding with the forceps, not peeling the membrane, because if I try to do that, probably sometime I will tear the retina because counter traction is the issue. So hold the membrane, forceps, and push the retina back. As you see here, my light pipe is pushing here, I am not pulling with the forceps. So, and however, sometimes this is exactly what you should not do. You try to pull membrane here, the retina gets stretched, and sometimes you land up top and trailing the retina, and the blood vessel give way here, and you land up sometime in a problem. So please avoid this type of complication as far as possible. Yes, these are anterior PVRs, tough for all of us. And most of these cases, we deal with a bimanual dissection. One was, previous session was shown with a keratoprosthesis trauma case. So anterior PVR, this was a 20 gauge video, actually, old one. Another one is giant tear. So hand on hand, you hold the membrane, tap the retina, and try to get the membranes out. But need, again, a lot of patience. Basically, things can be worked out if you are patient enough. Subretinal membranes, probably I won't go much detail because I think it will be the next talk. Somebody's talking about exclusively subretinal, so probably I'll leave it here. So additional steps, when you deal with a PVR, you may add scleral buckle or encircling band depending on where you need a support, vitreous base or aura. And if you were previously placed scleral buckle, usually we do not tend to remove. Retinotomy, usually if there is unrelieved traction or diffuse equatorial traction, foreshortening, or you have significant contraction and fibrosis probably, generally you use as a last resort, if at all. But once you decide to do retinotomy, you should be liberal enough, have a cautery done, peripherally and then cut those peripheral retina, but ensure anterior flap of the retina, which is necrotic, should be fully removed. Sometimes we can use one, but before that, remove all the membranes before attempting retinotomy. Probably put PFCL to stabilize the posterior pole rather than sometimes other retina is too mobile to settling it become difficult. But once that is done, we have under additional PFCL to settle the retina and subsequent laser. And this is what we added some more PFCL to flatten the retina, and then you do laser all around here. And this was the end of the picture. Silicone oil, obviously, most of these eyes, I will not go to because most of these eyes eventually will end up in a silicone oil unless they are superior isolated breaks and you get enough clear mobile retina. You may be able to get away with gas, but most of these eyes will need silicone oil. So to conclude, in detachments, periretinal membranes are predominantly due to exaggerated healing response, making retina stiff and immobile. Meticulous removal of all the membranes over entire retina is critical to remobilize the retina for successful reattachment and to minimize the recurrence of PVR. And choice of the instrument is obviously at a surgeon's discretion. Thank you very much for patient
Sir, excellent talk, sir. I would like to ask 2 points from you, sir. What is the role of intravitreal methotrexate according to you in these recurrent PVR cases? And second question is, sir, have you ever used heavy silicone oil in such cases, especially in inferior post-traumatic old retinal detachments?
Methotrexate, people already would have tried. People have tried Tricot, other issue. But I don't think we have, as of now, there's no concluding evidence that it is really beneficial. Even one of our colleagues were trying, once you do RR, he sprinkle Tricot all around, yes, and then put silicone oil over it, excess remove. But we have yet to analyze those data. We do not know whether it is beneficial or not. As far as heavy silicone oil, I do not have personal experience. In India, it is not as officially approved.
It is from Bosch and Lomb from US.
People are using, but I personally feel there is no substitute to clean membrane dissection and settling the retina. Because with heavy silicone oil, whatever literature we read is, we have superior PVR. If you put a regular silicone oil, you have inferior PVR. So ultimately, that's what you will end up in.
Thank you.
So actually, we use methotrexate in almost all cases.
Sorry?
Methotrexate.
So, methotrexate.
At the end of the surgery, 400 microgram and weekly 400 microgram, because half-life is only 5 to 8 hours. So it really helps. Actually, our paper is under review currently.
Good, we'll see.
And an alternate for heavy silicone oil is short-term tamponade of PFCL. We can retain it for a week or maybe maximum of 10 days, and then we can replace it with silicone oil.
We'll wait.
How many injections do you give?
Sir, at least for 5 till the end of first month we use.
So every week one injection,
every
5
week one
injections?
injection, intravitreal 400 micrograms.
Was it a comparative trial, Dr. Naresh? Or
Yes, sir, it's a comparative trial.
Okay, so can you share us the percentage
I don't
difference?
have the exact numbers now, but compared to the control arm, the results are better, sir. The reattachment is better.
But there's another trial.
Under silicone oil, no?
Under silicone.
There's another trial. I think the international trial is going on also.
Yeah, that is from, I think, by
So
Gene
We're not at the results. are not out.
Did you compare, Naresh Babu, did you compare this thing with a control group which is of similar degree of
Yes,
PVR?
almost similar, yes, sir.
So what is the difference?
No, the reattachment rate and the need for multiple surgeries is less in the methotrexate group.
One question, would you advocate use of dyes for immature membranes, any kind of dyes or staining?
Actually, we can use most of the time, again, trypan blue, you can try, but most of the time we can manage. I personally do not use, probably Tricot once in a while, just sprinkle a little bit, but not other dyes I not use. Because particularly when you have difficulty in inducing PVD, that's the time I use, but most of the time we manage it.
Immature membranes, what I would do is to stain the ILM with BBG and use that as a handle, because sometimes when you peel the ILM, then the immature membranes over the posterior pole get identified, and then we are able to peel it anteriorly.
The advantage, it gives a differential staining, so then you know that something is blocking there. That's the thing.
Actually, in patients who have, whom you're finding it difficult to settle after you've done everything, say you put PFCL and you still find it still lifted up.
Yes.
Sometimes it helps to remove the ILM as much as possible using staining with BBG. And before I come to the stage of retinectomy, I would actually prefer to give a buccal inferiorly. I mean, somehow I feel that doing extensive retinectomies leads to more hypotony as compared to a patient who gets a buccal 180 degrees inferiorly.
Yeah, that what I said. most of the PVR, I still try encirclage man, and if there are inferior breaks, I would still put a broad buckle before doing retinotomy.
Yeah.
I still do that one.
Yeah, I think that's the basic message, that retinectomy is actually the last thing.
Yeah, it is
After
the last
everything is done. But there's a tendency to take retinectomy in the beginning itself.
Agree.
You know.
That's a last step always. Yeah, thank you very much. I'll take this opportunity to invite all of you also your next Retina Summit in July, and theme will be ROP, and it is along with the Indian ROP Society as well.